Welcome. This is Dr. Sasha, and you are tuned in to Clinical Unfiltered. So give me your hearts, your minds, your teeth, and we're going to get unfiltered with Dr. Pauly about the periodontal classification system. I know you're like, "Ugh, Skip, don't skip. Listen, this is going to be freaking awesome. I'm going to make this awesome. And Dr. Pauly is going to make this awesome. So Dr. Pauly, real quick, before I kick it to you, we were in residency together. And if anyone's seen my presentation style, they know I like to like bring the fire and the heat. And I feel like Dr. Pauly was the only one keeping it real on the presentation level, and having fun with it and really doing a great job at connecting with people, which I think has really shined in her Instagram posts. And so through her Instagram posts, she's kind of done a really unique thing where I think you've been able to simplify the complex and bring it down so that we can all feel not as dumb about learning these things. And I believe that I have a whole spiel where I'm like, when you go back way when there was like cavemen and like shaman, they used to like teach things to each other around an open fire, and like there was soul to the knowledge. They used like superstition and to kind of make it more spicy, and teach things in the process. And then you get the Industrial Revolution, and then like we teach everyone in a factory style, and it's just all about memorization. Here's facts, memorization. Everyone's like ticky tacky in a classroom. And then I think with technology and social media and the right personalities, the ability to bring the soul back into the learning is possible. And I think we have, me and you are among some that have figured that out and been able to do it well. So guys, welcome Dr. Pauly. Thank you for joining us. Your Instagram, I'll let you take it away from here. Your Instagram is
Periodontal.
Periodontal, yes. And what spawned you to start making these posts? These like really digestible posts
Since this
on
is
Instagram.
like, as your introductory said, like raw, honest, I'm gonna tell you the
Yeah.
honest
It needs
truth.
to be
Yeah,
unfiltered.
unfiltered. So when I first graduated, I think I was in Pittsburgh just before the COVID outbreak, okay? And I was at this job as a young periodontist, just finished her residency.
Oh, you went right you went to Pittsburgh out of
I did.
residency.
And I
Oh, bad move.
did my
Sorry,
nails
sorry.
go
Hey, Dr. Andrew Velo, the other guy on this podcast with us, is from there. So I like
there.
to beat up Pittsburgh as much as I can.
I did go to dental school in Pitt. Okay, so
Yeah,
anyway, I went back.
double
I know.
whammy. Yeah.
I went back,
Yeah.
and the guy who hired me at that time, he was much older, and he was like, "Hey, Polly, like, I the reason why I bring you in is, I want someone who's new, who's fresh, to be able to do the social media thing. Okay, it's like part of your job." And just to showcase. He's like, wouldn't this be like a great way to showcase your cases and show the GPs, when you knock on doors, just be like, hey, these are my Instagram and this is like my cases. And I was like, well, I'm like, I don't know if I want to tap into that. That's like a whole different thing. It's a little bit out of my comfort zone, and I just didn't know much about it. But I feel like I have the obligation to be a good associate and try to bring what he thinks I can bring to this. So I started this Instagram, and it was like, I didn't know where I was going. All these dentists were dancing, doing the dances, and those were pretty well. I can't dance at all. And then I tried that, and it was not dancing. It was just my hand being like, it was very cringe. Like nobody,
Gotcha. That can work. That can
right?
work. That can
Nobody
still
really
work.
cared.
Gotcha.
But then, what was interesting about my Instagram is I ended up connecting with a bunch of really, really, really cool people on the platform. Okay, and then because very quickly after I think I worked there for like 2 weeks, no joke, and it was like, oh, COVID, that's shut down the office, so there goes my job. But
Gotcha.
I already started this Perio Poly, and I was like, well, now I have all the time in the world to maybe see what this Instagram is about, especially since I found like all these really cool connections, like, and we're still friends, and we have our like Perio happy hour. Well, a bunch of them.
Yeah, 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 gotcha. Okay, so that okay,
So that kept me going.
understood.
Yeah, and then I tried out a bunch of things, and I finally was like, I was studying for the Canadian Perio exam, which was like I think 6 hours long, $7,000, and I didn't want to fail. It only happens like once a year, so I have to go back and relearn this new classification. And so I was like, okay, I really need to pass this. So as I start to read all these articles, I'm like, dude, it's like this long. I printed them out. They're like this thick, right? And I'm reading through the abstracts. I'm like, oh wow, wow, like these sentences, like my eyes. I'm like just trying to, make sense of it. And then I started doing notes. And then I was like, hey, won't these notes be helpful for other people who's probably, taking this exam or even for their oral boards? And as I do my notes, it helps me learn. So that is how it started with the more educational posts. So then I started posting more educational stuff, and people are responding with, oh my gosh, I finally understood this, or, you break it down in a way that I can understand better. And I find that, yeah, some things can be very confusing. Some papers are very long, like we're in sciences, we're not in English. So I was like, well, let me do more of these. So that's how it started.
Gotcha. You found your niche in the explaining the article realm, which is, I mean, it's a thing. I mean, in residency, that was the whole. We had this section called Bottom Line where we would like go through. You remember, we would go through literature, and then you were set up to at the very end summarize it as best you can. I mean, the professors most of the time were like, try to summarize this in like 2 lines, bottom line, not bottom lines, bottom paragraph, bottom essay. And often it would be. And I'd get, honestly, I'd sit there and be frustrated. I'm like, guys, watch, back up. This is how a bottom line is done. Perio is bad, done. Like I would make it as simple as possible. Perio is calculus, and things like that. And I feel like that was lost upon many people. Just again, I think it's a problem because that's just how everyone. That's how you've been taught most of your life.
Yeah, we've been programmed. So I remember your presentations for residency. It was like, I look forward to it because it was different, it was unique, it captures my attention. I always learn something from it. So
Maybe. Yeah, it's exactly. Got your
you're,
attention. Yeah,
you're
I mean, I'll sneak a fact in. I'll sneak a fact in.
yeah, and so when I
Yeah.
saw your presentations and then I saw, all the templates they gave us to follow, and I'm like, dude, like I can't, I just can't present like that. That's just not my presentation style because it just, if I find it boring, I don't feel like I want to present that to people that find it boring as well. So I had, me, I had my own style presenting. And
I'm gonna show the post now because I'm gonna show you the post because like this is the thing. There we go. Sharing. Okay. So this is the most commonly tested must know perio classification series. New perio classification. So this classification came out 2017 World Workshop. This is what we're supposed to be using right now, and I'll tell you before that, I was using what like moderate periodontitis, localized, moderate, generalized, forever. And I honestly, you want to know something really sad? I think I just started trying to use it the end of last year, the new classification system, just because it was so uniquely hard. But what I did want to highlight in this post is that it is. I mean, if you can't see right now, if you're driving at the gym, I'll just explain it visually. It's visually appealing. The colors are nice, and it's describing a very complex paper. And really, it's annoying that that's the only intake that you can really get that information. So having it in this kind of format makes it so much easier to ingest. And again, with that said, I do want you to go through this post and kind of explain this classification as as you would you'd want someone to intake it basically.
right. I'll try my best, because we all know this topic, like
Go
you
for
said,
it.
is,
Yeah.
the most appealing, but it's what they love testing on. So unfortunately, we gotta know this stuff, especially now.
Well, let me ask you this. So as far as the periodontal classification goes, like, I mean, for insurance purposes, do they? I mean, in Canada, because you're in
I am.
Canada, does it matter for insurance reasons?
Canadian, for what I know as a periodontist, I'm not too sure about the GP, but in Canada we have something called like the fee guide. This happens with the GP as well, so it's totally different from the States. You know how in the States you get all these different insurances, and once you sign like a contract with them, you kind of have to, honor their fees. It's not like that here. So we every year they come out with a fee guide for different specialties and a fee guide for a GP. And the fee guide is just a guide. So it just tells you that, okay, this is kind of what the fee guide says to charge for this specific procedure. But you can go up if you want. I don't think anyone really go down. You're either at fee guide or up, is what I hear. Maybe okay.
I guess more out of this is like if you want to get that fee, like they're expecting a certain language sent to them, and in the notes, like you should like the general practice would be you're using the new classification system, not the old. Like you shouldn't be telling them that there's generalized, moderate, chronic periodontitis. You should be saying the new
Yeah, I
classification.
don't even know if that's like allowed.
A legality. I know. I don't know
I
either.
don't.
That's why I kept doing it.
Even when I was reading, at least like I work at all these offices and all the hygienists, they're really good at writing like the new classification. And well, a lot of them are newer grads, but they are really good. And then the GPs are really good. And then as perio, when we write our letters out to GP, we use the new classification. So I think that really like make people start, taking more attention about this, not just for insurances, but just for like, oh yeah, because I know I keep calling it new, Sasha, but it's like not new anymore. But I keep
It's
calling it
2017.
new.
I know. It's new to
Yeah,
me. It's new to me. That's why, because I just started taking on. Because I was like, I just finally like, I looked into myself. I looked
yeah,
myself in the periodontal
yeah.
mirror, and I was just like, the little tiny one, the circle. I was looking at my own reflection, and I was like, what am I doing? This is not generalized moderate. You can learn the stupid classification system. But I will tell you, the reason I think I've been averse to it is because if a new system comes out, you're hoping that it improves upon the past. And a part of that, a part of creating a classification system, a key component to me is communication. Because that is where, hence, all problems lie in communication. You create a system that's easy to communicate. I don't know if this was the best move. I'll be 100% honest. I don't know if when I saw this classification system, I said, this is easier to communicate. If I'm sitting back and having to think about it more, is it easier? Do you, I mean, you're obviously, you've intaked it, you've created these posts. Do you think this new classification system is easier than the last as far as communication? Like, as soon as you're, walking through a patient,
Yeah, I totally understand like where you're coming from because I was very
and you could say, yes, it's easier. I'm curious what your thought
I
process
think
is.
my thoughts have changed over the years when I got really like deep. I got really deep into this class with
Uh-huh.
oh my God, like I dove
Yeah.
in, right? Like
You became
yeah,
it, yeah.
yeah, yeah. Like I finished it,
Polly
I
is the
taught it.
periodontal
I even have a
classification.
PowerPoint about it. Now I'm making a guide about it. I'm like all in. Okay, but in the beginning, remember I was a hygienist before I was a periodontist. So I learned the old classification back when I was like 18 years old. I'm 40 now, right? Okay. So I was a hygienist. I graduated 20 to 26 years old. 26, I went to dental school. So for 6 years, I've been using that. My whole brain is that. Okay. So when this first came out, I was like, "Oh my gosh, why do they do this?" Like when people finally understand, like when everybody's on the same page with this generalized, localized, aggressive perio and like biologic width, like why, right? And then, so actually, when I was driving, I know this is such a nerdy thing, but then when I was really studying for my exam and trying to make all these guides, because I want them to be as accurate, they need to be accurate for study guides and all that. And I just feel like, okay, I need to open my mind to this. So I went on YouTube while I was driving to work like 45 minutes and I listened to the American Perio like association YouTube videos with the experts saying why. And I'm starting to think, okay, I think I see why. And we'll
Okay,
talk more
interesting.
about that as we go through the term.
Change my mind right
I don't
now.
know
Let's do
if I can. Yeah.
it.
but
No biggie. No pressure. Just
No,
change
no,
my
no.
whole mind. Here
I
you
do see there is, yeah, there is some merit to this. Yeah,
go.
yeah.
Okay, go.
Okay.
New perio classification, Polly. You got the stage. Change my mind and anyone else who's with me. But I honestly, probably a lot of younger doctors listen to this and they're like, Dr. Sasha's not being like an old fart.
No,
This is
it's
like all he
honestly,
knows.
it's not that. It's just human nature. If we learn this first and then you tell us to learn the old classification, what do you think will happen? I think we're just like,
I think I might be like, this is great. This is the way. Way to go. We've improved.
seriously? Okay.
I'm messing with you.
Maybe. I don't know. Because I think to me, that's what it is. It's like, we're dentists. Sometimes we're all pretty stubborn. We got that thing to us. And then when we were taught this, that's how it should
Right.
be.
This is not this is just
This
a
is how
human
it is.
nature
Yeah, this
thing.
is
Is
how it is.
change.
So I start to think, hey, if I were to learn this and I look back at the old classification, I would be like, well, what if the person have diabetes? What if the person is a smoker? Well, this thing didn't really tell me about the rate of progression or prediction of that. Maybe staging and grading will make the patient take this more seriously because it sounds like cancer classification.
Yeah. No, that is true. I mean, I thought that was the whole purpose. I was like, oh, we're just communicating to them that this is bad.
But I don't know if I agree with some of it, like, because we'll get to that. Like,
Okay.
yeah.
So let me know if you want me to move forward on
Yeah,
it.
let's go. Mm,
Next.
yeah, next. So this post is mainly about old terms versus new terms, because I think before I even introduce the classification, we need to talk about this because there are some terms that we just, the classification is like, oh, that's outdated. We shouldn't use it anymore. So for all the new papers, all of these new terms come out and not the old terms. So if you're not familiar with it, you'll revert back to the old terms, right? So one of them is biologic with our favorite. So instead, they're calling it supracrustal attached tissues or supracrustal tissue attachment. And I remember,
Wait.
yeah,
I'm calling foul already. Why an or? Why create an or? Is it just me?
no, okay, but if you
No.
think if the glass is full, the good thing about or is you can just choose one and use it on your oral boards. You don't have to.
Oh,
Well, I think of
okay.
it like that. I think of it like that. Yeah. So for me, it's all about like easy memorization, whatever helps. So I choose supracrustal attached tissues because it's SAT.
So you're telling me a circle of experts were in a room and they were like, guys, we're going to do supercrustal. I'm assuming this is how it went. We're going to do supercrustal attached tissues. And then there's a guy in the other side of the room who's like, obviously on his phone and not paying attention. It's like, yeah, it's going to be supercrustal tissue attachment. It's like, no, dude, I said supercrustal attached tissues. And then there's a guy in the middle who's like, whatever, both. And then they just put that in the classification system. I'm assuming that's how it went down. I'm not gonna lie. So far, I'm going with old term here. I'm giving point to old term.
I actually, you know how I said I dove in deep? I actually read every single line in the paper when I was looking at this. I listened to their interview. I dove in. So I think I remember someone said the reason why they made it like this is because biologic width doesn't make sense. Like if you just listen to that term as like a person, like not a dentist or anything. Biologic width is like it's kind of arbitrary, it's kind of out there. What's biologic about this width? But if you think about supracrustal attached tissues, they say it's describing exactly what it is. If you think about it, it is describing exactly what that thing is, you know? So that's where this term apparently comes from. I
Okay,
know. I see. I
fair,
dove in
fair.
deep. I
Yeah, that's fair. I'm just saying why they make two terms and why are they willy nilly about it about that point?
know,
Like why
right?
that's the thing they were like laxed on. They're like attached tissues attachment. But the
They both
no, I
can
kind of get what you're saying.
describe it.
That's fair.
Yeah, yeah. So
That's
that's
fair. Biologic width.
yeah.
That's
So
fair.
they're saying, hey, if we write like a report to the dentist and we write biologic with, they're like, but then it's like if we write supracrustal attached tissues, they're gonna know that it refers to the supracrustal attached tissues, which is the junctional epithelium and the supracrustal connective tissue. That's their process.
Gotcha.
You're describing exactly what it is. So if you think of it like that, does it make you feel better, Sasha?
Well, I mean, I mean, but they're equivalent. That is what biologic width is. It's supracrustal attached tissue. The biologic width, and this is the thing they always used to tell us this. It refers to the junctional epithelium and the supracrustal connective tissue. They always used to say that like that's what it is. Um, but as a part of this new term saying that this is actually like the attached version of it. Like this is saying these tissues are attached. Hence the junctional epithelium is like adhered and then the connective tissue is actually like kind of
Yeah.
attached.
So if you
Whereas like biologic width doesn't distinguish that it's attached.
so are
Okay.
you being
Got it.
influenced right now a little bit?
A little bit, a little bit. You're
Yeah, a
winning. You're
little
starting
bit.
to
You're
win.
kind of a
Okay.
bit
All
of a
right.
nerd.
All
Yeah.
right. But I will tell you, biologic width is a way better like title to a
Well, because
movie.
it's shorter. It's shorter, you know, to say.
Yeah. Yeah.
Yeah, yeah. But
Yeah.
that's where this concept came from. Yeah. Yeah. Okay, now the next one. O term. Excessive occlusal forces. You know what? I honestly, when I was a dental student, I didn't really care that much about what these terms are called, like occlusal forces and excessive occlusal forces. So this isn't as ingrained in my head as like biologic width. So this is an easy change for me. What about you?
Yeah. Oh, I see what you're saying. Yeah. Yeah. I would have interchanged these
Like I
probably
wouldn't be like, oh, that
anyways.
that that bothered me. You know, biologic width
No,
would be like, oh, that bothered me. Like,
no, yeah, no, fair. Biologic width was more controversial than this. Honestly, I like traumatic because like
like it.
there is, I mean,
Uh,
yeah, this one I like. This one's actually a little bit more clarity for sure. Because trauma, and especially from a standpoint of like if you say so you got excessive occlusal forces, like a dude might come in and be like, hell yeah, I do. I've got some. Yeah, I'm excessive as hell. Like I'm really excessive. Where that sometimes doesn't like trigger a bad thought, but traumatic does. Like a traumatic type of force. So I like that the traumatic occlusal forces over the excessive. Yeah. But it suggests because that knows it's a problem. It's like you said, injury, trauma, injury, problem.
because what do they say? If something's in like, their homeostasis or like equilibrium, it may not be traumatic, right? But this is actually like trauma causing an injury. So that's why I bolded the word injury there. It's any occlusal force,
I saw that.
yeah, that results in injury of the teeth or periodontal attachment apparatus. So you like that? Yeah,
I do like that one.
see?
Yeah, I'm cool with
And
this
it's
one.
like
I'm floating. I'm not
2F.
arguing
That's
with
what
it.
I remember.
Yeah.
Yes. Next. Okay. Old term versus new term. How do you feel about this one? Aggressive periodontitis.
Oh my God. Well, the new term is a paragraph. Is that what I'm
It
reading here?
is.
So
So, okay, the new
okay.
term. Do
Eh.
you want me to
I
go,
mean,
go into it?
instinctually aggressive periodontitis for the win on this one on old terms, from the old classification. Okay, go ahead.
I,
Try.
I, I actually agree with you on this because the
Oh,
other day, I had a patient came in, she's like young, 25 years old, and she obviously have this aggressive periodontitis. I just feel like, I told her, I was like, hey, you have this, this condition, and what we call it before is aggressive periodontitis because it's an aggressive thing, we're at your
yeah.
age, I shouldn't see this much like disruption
So
and
the new
attachment.
the new term is
Okay, so the new
is
term,
is it is it molar incisor pattern? Is that what it?
so there's two, right? So the new term, if you think of it as, the new term is no matter what it is periodontitis. And they have their reason behind this too, because they're like, well, the etiology behind aggressive periodontitis when they go through all the papers and all that is the same as periodontitis. So they didn't feel like they have to have another term to describe it as a separate entity because of their etiology. So in the end, it's going to be categorized the same way as we would when we stage them. So it can be, for example, like stage 3 grade C. It's all going to be grade C because I think it's going to be grade C because you're seeing like, the age. For example, they say grade C is if the person's 30 years old and you're seeing, 30% or more destruction on the x-ray, which we usually do, for aggressive, but it's now called this, then it's grade C, where it's progressing faster. So yeah, and then you say it's either generalized because you know how I'm gonna say I'm gonna use the term aggressive perio just because it's easier. How aggressive perio? No, because this I
Yeah, yeah, you agree. I
with
got you.
you on this.
Yeah.
Aggressive perio, when they have it at a young age and then they don't go see the dentist, and then by the time you see them, it's not just molar incisor anymore, right? It's like
Hmm.
premolars as well. So then they take that into consideration. So they're like, okay, there's two ways. It's either generalized, like you would still say generalized when you see it everywhere, or if you would say molar incisor pattern when you see the classic, molar and incisors involved. So that's their take on it. I
A
know, I
tack
know,
on
I know,
term.
I know, I know.
Yeah, it's like a tack on term.
But but
Interesting.
the reason being is, yeah, and there's no difference
See,
from what
I
caused the destruction, right? Like I see their point too. It's just,
but the thing is, I mean, from a treatment standpoint, I mean, I'm assuming these guys who were talking about it are also there's a portion of them that are clinicians coming up with this. I mean, they have to know that aggressive periodontitis is going to play better with urgency.
yeah,
Like that's a I mean that's a big point. That's the thing. I do feel like as much as this is for interclinician communication, there has to be a thought process of how we communicate it with the patient. Obviously, with the staging and the grading system, where it's like, and just for clarification again, staging is the like the severity, correct?
mm-hmm.
Stage one is
Okay, I have like actually one post on it when it's just one diagram. That's a lot easier. But basically, for stage, you're looking at the severity and the complexity, and then the extent. It's like a big chart on the papers. I'll try to do it like, I don't know, like within 20 seconds. Um, stage, you're looking at one, two, three, and four, and you're checking to see the interdental clinical attachment loss at the greatest site. Okay, and then if you don't, then you're looking at radiographic bone loss, and then you're also considering tooth loss. So to make it simple, they had this chart that's interdental clinical attachment loss. I'm just gonna call it CAL. If it's 1 to 2 millimeter, it's stage one. Stage two are 3 to 4, and then stage three and stage four is 5 millimeters or more. So if you even have like one single point of, we're going to talk about this, so we're going to have just 1 6 millimeters, right, of interdental CAL at the greatest site, then you're automatically stage three. And then there's also other complexities that go underneath it. It's not just probing depth. Of course, we're looking at radiographic bone loss, tooth loss, and also like local factors like is there furcation involvement? But there are trump cards. Like I went to a course and then they tell us like, oh, there are these trump cards. And I like the way they say that. So that once you see furcation class 2 or 3, they're automatically stage 3.
and I think is it gets lost in that process of being like, okay, once you have that, you have this. And I feel like people approach it from like a black white, like, okay, that what they're trying to imply by saying that is like once you have furcation involvements, shit starts to get tougher to manage. And like once you have furcations that are exposed, if you've scuba dived under gum tissue as much as we have, you know that even when you get it clean, you're sitting back. I'm sitting back. I'm like, man, how is the poor patient going to keep this clean? And it comes from a prognostic standpoint too, where it's like you're staging them further along because it's just a much more dire situation for the tooth and their general periodontal health. And I think that gets lost on people is that they're like, okay, there's stage two, but not a stage three because there's a furcal. I feel like that, and that's actually why I don't like this system because it like tries to like black and white a little bit too much, and like being like when I look at a patient, I have to obviously stared at enough perio. I'll just look at their X-rays and their I'll look in their mouth. Sometimes I still believe the power of the probe is kind of stupid. I'm like, it's the year 2026. We're taking a stick with freaking lines on it and being like, this is the
And
panacea
there's
of
also
determining your gum
you
disease.
know, air
And I'm like,
reading it and all that and the pressure,
right?
right? Yeah.
Yeah, and so I sit there and I look at it and I'm just like I can look at the whole system and be like, all right, you kind of got this gum disease relatively bad, or you're in the middle, or you know what, it's not that bad. It's just starting. Hence, this is why I love the like early, moderate to severe because it like summarizes that a little bit more because that's how I conceptualize it too. So like staging it, and then I'm like, wait, stage was it stage two to great? Look, you've got gum disease bad, and it's happening fast. We got to do something now, and that's really what matters to the patient, really, and honestly, to communicate to anybody else. That's the ultimate. That's the ultimate point of it. Now, granted, I get it. You got to somehow create some kind of
Right.
unionization so not everyone's in the wild, wild west.
1000%. But what's interesting in like all these like newer updates, it's like they write in fine print that still use your clinical judgment when you stage.
I would write it in bold print. I'd be like, look, if you're having a hard time determining if this person needs help or not, just like, go sell Bitcoin.
Believe it or not,
You
like,
know?
you know what you said about talking to patients, just very recently, I would say starting like last year, maybe in October, is switched and I try to tell them their diagnosis using this new system. And I find that the way I say it, obviously not to dentists, but to patients, the way I say it, it's like, okay, there are like 4 stages in perio, and you have like bone loss around your teeth, basically, on some of the sites, right? Show them the x-ray, and I go, there's a stage 1, 2, 3, 4. 4 is the worst, and you're at stage 3, so you're close to, moving forward. And I just ended at that. Cause it's like there's no point of me going. I was just like, okay, this is like a 1, 2, 3, 4 kind of scale, right? You're at 3, and I find that okay. But it's like what you said. But it's like what you said. If we were to use the old classification, I don't have to tell them there's a scale because mild would just be mild, moderate would just be moderate, right?
Yeah. Hey, you know what? I'm wondering if we had visuals in the room where it like visualize, you know how they I feel like they have things like that where it's like, and it would be showing, it'd be an image of stage one gum disease, stage two, stage three, and stage four, like a big one. So that when you're saying that, they're seeing this poster in the corner of the room or a visual on a
Like the
screen and
eye
being like,
doctor, right? With all the
yeah, yeah, exactly. I mean, I don't know of an office that has that up. I don't know if offices even do that anymore, where they have like infomercials in their room. That was a thing back in the day. I feel like you'd go to any clinic, they would have an infomercial
yeah.
of
Oh yeah,
stuff in the room. Now it's like
yeah.
minimalism,
True.
it's spas,
True.
so you don't do that.
True.
But I do think it creates a communication barrier based off what I'm still seeing is a little bit of what I was fearful of when I was doing it because I still have to do it. It's like I remember I was trying it not too long ago. I was like stage two, grade B periodontitis, and in my head I have to like again just because I'm new to it, be like, is this what I really want for this? And then I always have to roll my chair out in front of the patient and be like, this is what it means, you know. So I still have to like follow up with it. Worried when I send that information to another dentist, it won't click when they just read the notes, like what the severity really is. I don't think it clicks visually as
I
hard.
used to, when the new classification just came out, when I was writing the referrals, I used to put down both. I just I
Both,
just
yeah.
don't anymore now because I'm like, okay, it's technically not that new
And no
anymore.
one's barked back.
And yeah, dude,
No one's been like, what's going on with the
no,
patient? Is this good or
no,
bad? Is this good
no,
or
no,
bad?
no, no,
Okay,
no.
good.
Mm-mm.
Good. So everyone's on. All right. I am going to be using it more, but I do find that there is that communication barrier that I'm
And
still running
like I
into
said,
with my
I
patients.
like some things. I like some things, but there are some things where I'm like, oh, I do miss that about the old one. And like I said, aggressive perio is one.
Yeah, that one I agree. All right, moved it on to necrotizing. Yeah, you know what? I get funneled it. I feel like sometimes because they'll see it, they'll send it. I don't think they know I don't think they would consider it necrotizing in the moment, but normally like the friability of the tissue gives it away. Um, and I have no, I have gotten it before. I have gotten it. I would say probably like one every other month, not a lot.
This one isn't a huge change. I like the new change. So easy. Yeah. Because they're like, oh, necrotizing and ulcerative, it's kind of like similar. Like we get the gist of it, and then I just take out ulcerative. You like this one? I like this one. Yeah, yeah, yeah. So some things like you're like, okay, they thought it through.
Yeah, I feel like necrotizing ulcerative is redundant. Yeah, it's like a very, very, very good. It's very good.
How do you like this one? Remember, like we all love the Miller classification.
Okay. Got it. Okay. Got it. Which matters the most because this is actually for the sake of like, do you treat it, or like, what's your predictability of treating it factors in pretty easily here because that's what I'm looking at. It's like when a patient's like, how much more gum tissue can I anticipate? I'm like, well, you got bone loss in between the teeth, um, and it's almost worse than the bone loss in front of the tooth. So we're not going to get much. um, Whereas if the bone loss is worse on the facial than it is interproximally, we have a better shot. And then of course, if there's no bone loss on interproximally, then even better. That's like the best shot. So type 1's got the best shot. Type 2, slightly less good shot. Type 3, the worst shot. You're probably not getting anything. You're not getting any kind of growth of gum tissue up on a tooth. Okay, that's not bad.
So when I really dug into this, it's interesting because Miller wrote a journal article responding kind of to the Cairo.
Oh, no way. They just diss tracked each other?
No, well, no, he updated. I think there's a couple lines saying that, yes, he knows there's a 2018, the new classification. So, his article, he updated it also and published it in
So
2018.
Miller, after Cairo comes out with his article that gets
Yes.
becomes the new classification system, Miller's like, oh hell no. Was it
Well,
that
he's
kind of
not.
tone? Yeah, I wish I
No, I
knew.
don't think
I wish I
so.
knew. I
I
wish I
don't.
was with Miller when he saw this shit and was
I
like,
don't think so. No. Oh, that's like
Miller, are you out there? You're never gonna listen to this. This is just not your jam. But if it is, if someone knows Miller, I want to know. I
so
want to know
so
what happened
yeah.
in the room where it happened. In the
I'll
room where
send
it
you the
happened.
paper and you can
Yeah.
let me know what his tone is like. But
I want to
he
know. Let's put.
basically
I mean,
was
let's get
saying how
Cairo and Miller, yeah, in the same room, and let's see what happens. Gloves off,
yeah, 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 yeah.
debate it out.
I actually really like the Miller classification.
Okay.
This is a hard switch for
No,
me,
I mean,
but
the
I
Miller
understand.
classification was a great. Like I had quarrels with it. I mean, granted, we were taught it, but it sunk in pretty easily. And again, it was the same thing. It was like kind of give a good explanation on like how predictable is your grafting going to be associated with the classification, which matters.
I think both are pretty easy to understand, but the problem is I feel like when I read papers on I sound so nerdy, but when I read papers on soft tissue, like a lot of them are using Miller classification. So then when I read the conclusion about like how much percentage they can get and stuff, they're using Miller classification. So it almost makes me think when I'm doing a procedure, I'm looking at it because I want to base it on, the studies and stuff. I have to categorize it as Miller first to be able to get that conclusion.
Gotcha. And so that's actually an intriguing point because a lot of the research would be based off that classification. Even though they changed it, all the old, yeah, okay, so all your predictability is based off the Miller, but now you're looking at the Cairo. Well, I will tell you, like in a clinical setting, I do like this Cairo is so much more simplistic from a quick write down standpoint. The Miller classification is almost like ingrained into me. Like I almost understand it to its core where I can look at it through. Like I'm not sitting there being like, all right, I'm not writing Miller 2, which means this. I'm looking at it in my head. I'm like, okay, it's this type of situation. This is probably what I can likely achieve out of the soft tissue grafting. And from just a documentation standpoint, the Cairo is a little bit more streamlined in the newer classification. So I will tell you, I mean, overall, if this is some of the old stuff compared to some of the new stuff, there's actually some stuff I do like. There's some stuff I don't. The staging and the grading, I'm still not like super fond about. Just because I feel like I can tell my main thing is communication. I feel like that's critical. in beginning any kind of therapy. And so, for my understanding, and if anyone ever cares when they're making a new classification system, the whole point of classification is for communication to patients and to doctors. And you want to simplify the communication as much as possible. I will tell you, I'd be intrigued to like when an AGI or I can throw this back to ChatGPT to be like, hey, like,
Which one do you like more? So, so I'm just like pulling up my post on, do you know, the Miller updated classification in 2018? And honestly, I didn't even know this paper existed until I was doing my like deep dives, right? So he added papilla form in the classification. He's like, I'm gonna add type A, B, and type C in addition to my Miller classification.
So you had this further up in your. Is this the Miller class?
It looks like this. It's not one of my typical because it's a yeah, it's gonna be this one.
Where'd you go? There you
It's not the typical yellow.
go. Okay, gotcha. So it's not the typical looking post. Okay,
Yeah, yeah. So these posts get missed,
gotcha,
but they're important. So I might
gotcha.
just like reform them and make it typical yellow. But it's interesting. So yeah. He made a response to the Cairo, right? He's like, I know that you guys are switching to Cairo, right? But then, hey, I think let me add these other updated stuff that I think would benefit and that would like, make my classification even more complete.
Yeah. So I mean, I will tell you the like a take home on this discussion is I honestly think there's I mean it's as I think most people have kind of agreed to is not perfect. They're trying. And I think they need yeah. And I do think I mean as always they'll always try to re-up or redo the classification system. I'm very curious how AI will play a role in helping maybe develop that classification system. I'm curious. I'm curious if it'll play a role in developing it. I would love to give it a try. I'm going to give it a try. I'm going to do it. I don't need a council of doctors. I'm going to run through.
This one's here to stay for a little longer,
Oh yeah,
I
yeah.
think.
I
Yeah. So type A papilla that he added was no interproximal bone loss, and the papilla is 3 millimeter and up, like wide.
gotcha. Okay.
And then type B is no interproximal bone loss, but less than 3 millimeter wide. And then he predict that with that kind of papilla, the complete root coverage is compromised. So I think this is actually kind of cool. Like you're looking at how fat,
The
the
papilla
papilla is.
is. Yeah, but again,
Right.
that's just something that's like at this point it's intuitive to me is that when I look at the papillas and I'm like, okay, there's lots of blood supply there. I'm gonna have a
Mm-hmm.
better chance at
Yeah.
like I wish I like if you really want to simplify the whole like recession coverage
Yeah.
process, think blood supply.
Yeah.
Like if there's
Yeah.
if there's
Yeah.
interproximal bone loss, you know, you're gonna
Yeah.
have less blood supply
So
because there's
this
less
one is
tissue there.
right. But he's saying that even without interproximal bone loss, if you have a type B papilla, which is three, yeah, which is less than 3 millimeter wide, he says the complete root coverage predictability is still compromised. So he's saying that even without interproximal bone loss, if the papilla is
Like narrow
narrow,
thing.
it would still
Oh, absolutely.
yeah,
It's tiny. Like you're
yeah,
like, what are you
yeah.
actually
So
attaching to? Is
yeah,
it
less than three, right? So I think I like that he added this. Yeah, but
that's like
it
a
just
comeback?
it'll obviously make the whole thing
Probably what I'm asking
more
is, would he
complicated.
have
But it
done it?
forced you
Would
to
he
think
have done
about
it if
this.
Cairo didn't do that? If Cairo didn't come up and win out that classification system as a part of it, would Miller have been like, oh, wait, guys,
Let
wait,
me add
real
this.
quick,
Yeah.
do shade on it.
Yeah.
I want
So
it. You
then
know what?
type C. Yeah.
I mean, the Miller classification system, if that is like, if you're getting into soft tissue grafting, I think you need to still know it. Because again, if you're going to understand what you're going to achieve, like to understand the foundation of what you can achieve, you need to know that. But if you're going to actually, if you're not doing it and you're just communicating recession to each other, the Cairo for me is probably the easiest to do it. But I want to get into treatment in a second here because you have that treatment post while I was looking in there. So we're gonna end this episode right here. And if you want to know more about these posts, again, just go to Periopoly. Although you said you're gonna make potentially, hopefully soon, a Spark Notes version of this.
Potentially, hopefully, I know. Yeah, that's down
I'm
the road.
forcing this upon you by throwing it into the ether for everyone listening. And again, as we wrap up this episode, thank you again. Click, comment, like, follow, and follow Perio Poly and comment. Guys, thank you so much for getting unfiltered with us today.